So it looks like we're getting close to noon or right at noon. So I'm going to go ahead and get us started. For those of you who do not know me, I am Laura Evans, the Director of National and State Policy with Vibrant Emotional Health. And I'm very excited to be our facilitator for the Crisis Jam this week. And I appreciate everyone joining today. As I mentioned, there are a lot of conferences going on right now, including the SOSOZE Conference Foundation Summit on Decriminalizing Mental Illness. And I had the pleasure of speaking with Angela Kimball from Inseparable, Dr. Charles Browning from RI, Tiffany Russell from Pew Charitable Trust. It was a phenomenal discussion, as always, just in all the work that is being led in various components of 988 implementation. So lots of creative ideas, lots of considerations for us to think through, and just wanted to highlight that because it was also good to see people in person again. And I know a lot of folks who are usually on this jam were at the conference, either streaming or in person. So just wanted to thank everyone for joining us today, and let's keep the good ideas flowing. So this week, we're going to be talking about Children's Crisis Services. That's going to be the feature presentation from SAMHSA and Melinda Baldwin. So we'll have that to look forward to. We move to the next slide. Okay, so we're seeing this jam grow and grow each week. And we're so thankful for that because that allows us to have more perspectives to be shared. So we're at over 60 national organizations, participation from all 50 states and the offices of behavioral health, 10 states and their Medicaid offices are participating. We have over 2,000 emails on the email list, and kind of that high water line of 367 participants in that September 15th meeting. So again, let's keep the information flowing. If you think there's anyone who would benefit from this or that we can benefit from, please invite them to the jam. You can find the information on talk.crisisnow.com. And again, you'll see right as soon as you get there, the Zoom link, how to sign up for the newsletter, the past Crisis Jam calls, and any materials that were shared or presentations. And then as you scroll through down through that website, very easy to watch it on the screen there, pull up the slides, see the quote. So really kind of have this designed to make this easy for people to access information. And, again, talk.crisisnow.com and make sure that you check it out. All right, and so the quote for this week comes from the Surgeon General and the report the advisory that was issued December 7th of this year. And it's the challenges today's generation of young people face are unprecedented and uniquely hard to navigate. And the effect these challenges have had on their mental health is devastating. And so just some additional context around this advisory. So there was even pre-COVID, right, analysis and reports done on mental well-being for young people. And it found that feelings of hopelessness went up 40%. So that's effectively 1 in 3 students reported feelings of hopelessness or sadness. And so again, we're seeing more young people kind of dealing with their mental health challenges, which we think is helpful, right? We're destigmatizing talking about this, but again, we need to make sure that we have really robust services to help people and work through their crisis. So just wanted to highlight that here. I thought this was a really great quote. And it also leads me, because I'm on the policy side of things, just to note that a lot of states are considering or talking through adding the Lifeline phone number and other helpline phone numbers to student ID bills. So again, really want to make sure we're serving young people and letting them know that this is just a moment, it gets better and we can work through it. So at this point, I'm going to turn it over to Dr. Melinda Baldwin to go through the feature presentation.
Thanks so much, Laura, and good morning, everyone, or good afternoon, depending on where you are. Thank you so much for your time this morning. I'm so happy to be here. I do want to express a deep appreciation to David Covington for his work in bringing this learning community together, and to all of you. I learned so much from you each time we gather, and appreciate the work that you are doing in your communities across the country. I owe a debt of gratitude to all who participated in our listening sessions, which we'll share our information from today, on our expert panel, our colleagues at the University of Maryland, and my SAMHSA colleagues for all their work and support. Thank you very much. I'm Melinda Baldwin, the Director of the Division of Prevention, Traumatic Stress, and Special Programs. That's an awfully long title for what we affectionately call at the Center for Mental Health Services, the Children's Division. We now have programs across the developmental spectrum, ranging from our infant and early childhood mental health work to our work with adolescents and young adults. And we also have programs across the intervention spectrum, from promotion and prevention through our work with children and youth with serious emotional disturbances. Next slide, please, Laura. I want to highlight SAMHSA's priorities. As you know, SAMHSA is the only agency within the U.S. Department of Health and Human Services that is exclusively charged with leading public health efforts to advance the behavioral health of the nation. Our mission is to reduce the impact of substance use and mental illness on America's communities. So as you can see, the 5 priorities there, and then there are 4 cross-cutting principles that touch each of those priorities: the need for equity and inclusion, the concern about the need for a qualified workforce, financing, how are we going to cover the cost of the services that we talk about, and to ensure that the appropriate services are available during recovery or following a crisis. But as you take a minute to reflect on these priorities, you can see that a children's crisis continuum touches all of them. And so what I want to talk to you today about is the work we're doing at SAMHSA around children's crisis. We are in an unprecedented time with an unprecedented opportunity available to us to stand up a crisis system in this country that is responsive to the needs of our citizens, that can provide the level and quality of support they need to live healthy and productive lives. As you know, suicide is the 10th leading cause of death for all Americans, and suicide are on the rise for many demographic groups, particularly Black youth. COVID-19 has exacerbated the need for urgent behavioral health services, with rising emergency department use for mental health concerns. A comprehensive children's crisis system and mobile response will build capacity in communities to respond to mental health concerns using home and community-based services. We know that children and adolescents are developmentally different than adults and are connected to many different systems, such as education, child welfare, juvenile justice, and pediatric care. SAMHSA believes in a crisis continuum of care, which includes all 3 parts of the framework: someone to call, someone to respond. And what I would like to challenge you today to think about is that 3rd step in the continuum, somewhere to go. So we think about how can we frame it so it can be specifically designed to meet the needs of children and their families. As we know, this is necessary to de-escalate a crisis before more restrictive and costly interventions become necessary, and to ensure we connect families to necessary services and support. Next slide, please. We began this work with the firm belief that we need a crisis system that's responsive to the unique needs of children, youth, and young adults and their families. And the work we had done up until that point hadn't focused specifically on children. And we know that caregivers and their children are different, right? Caregivers and children are interconnected in their relationships. And thus, crisis situations for children significantly impact the parent or caregiver's ability to respond to the crisis and to de-escalate the situation. Supporting the caregiver's response to their child's behavioral health crisis decreases the likelihood of child welfare and juvenile justice involvement. As leaders, we cannot ignore the disproportionate outcomes associated with policing on our historically underserved communities, including our Black and Latinx communities, our families with children facing housing instability or homelessness, and our communities with low socioeconomic status. So in working with children and their families, we need a range of culturally and linguistically competent approaches that work in concert with children and youth in these communities. Next slide, please. So what are we doing? We held 4 expert panel meetings. So we brought experts from across the country to deconstruct the SAMHSA toolkit, which you are probably very familiar with on our website, and refashion it in a way to meet the unique needs of children and their families. This group met on 4 occasions, and it was an incredibly committed group. I mean, this is a group that we met for 3 hours straight. No one took a break. And we went the entire time. We asked the expert panel not only to think about the different parts of the framework, but to consider the special considerations of children and families in rural and frontier communities, for those who have intellectual and developmental disabilities, for children on the autism spectrum, for our early childhood population, and for transition age youth and young adults. And so throughout our discussions, we also asked our experts, what is it that SAMHSA needs to know? And what they responded to us, both in our expert panel and in our listening sessions, that children and youth systems are different, that we need to consider how to engage youth and young adults using technology. There was a lot of concerns about workforce, not only that it's limited, but that states are having trouble affording them, and that we should include as many voices as possible in the development of this toolkit. So we've done exactly that. We've held listening sessions with families, youth and young adults, NASHMD youth directors and commissioners, representatives from SAMHSA grantees and other child-serving organizations. We have an additional listening session scheduled in early January with tribal grantees and communities, and we're very excited to include them more in the discussion. Next slide, please. So in all of those listening sessions, I want to share with you the themes that came out and also some of the concerns. And so I think we've had about 15 listening sessions up to this point. How important family and youth peers are. The peer support specialist can play a unique role in the crisis response to children. And especially with youth, although having a responsive crisis system is important, we should continue to focus on crisis prevention. That mobile response should be dispatched when the family and youth request. Callers should define the need for that mobile response. That response and the services should be equitable and accessible for all, regardless of their insurance, their Medicaid eligibility. They should be trauma-informed and culturally appropriate. And there's a specific need for staff to have child and family expertise, to have knowledge of how those of the child and family serving systems, and their services work in particular communities. So not just how they work in the abstract, but how they're working in a particular context, and to have specialized training as to how to engage with a family system. And it's very crucial that those responding to a crisis are connected with their community. Next slide, please. We also heard concerns. Folks are very concerned about there's a lack of a child and family crisis response system. There were concerns raised about how their community is going to make the connection between 988 and what they already have established, their local warm lines and their response teams. Is their community going to have the ability to meet the increased requests for response? We heard from our rural community members that they have particular concerns about the availability of services and that their ability to respond to crisis calls. That there's just a lack of community-based services, especially for respite care, the workforce shortage, safety concerns, not only to keep our children, youth, and young adults safe, but also for staff. Fiscal impact, what will it be? How will we manage it? And then consent. This came up in all different places, both for families and youth. The need to have child and family specific data collection and outcome measures. And most importantly, the need for coordination and partnerships with our schools, our police departments, our hospitals, and emergency departments. Next slide, please. So in the meetings with our expert panel and our listening sessions, we use the framework in SAMHSA's National Guidelines for Behavioral Health Crisis Care: someone to call, someone to respond, and somewhere to go. And so as we deconstructed this framework, we considered in each of these categories how the minimum expectations and the best practice guidelines should be framed within a children's crisis continuum, a system that would be specifically designed to meet the needs of children and their families. And so many of these recommendations cut across all three of the areas, such as consent laws, the importance of training, and the use of both family and youth peer support specialists. And so I do have a caveat before I go into some of the things that were talked about, is I'm only touching on a sampling of what was discussed during all of these meetings and listening sessions. Next slide, please. Whoops, go back a slide, I'm sorry. Assessing for, when we think about somewhere to call, it was very important in working with children and families that we assess for other risk factors. So the risk of harm to others, aggression, domestic violence in the larger family, interpartner violence, self-injurious behavior, a history of trauma, access to firearms or weapons, suspected victims of human trafficking, or if there's the youth is missing. And what is the supervision? What are the resources involved, resource available to the family? That we need to use targeted screening and assessment instruments that have been developed for particular developmental stages, for early childhood, for adolescents, for young adults. To use those same screening instruments and approaches that will minimize racial and other biases, and to be mindful of algorithmic bias, and to consider the implications of these screenings and assessment tools in light of mandated reporter requirements. Now, next slide now, please. Thank you. So when we think about someone to respond, we know that when a response team, involving one or more licensed behavioral health clinicians is dispatched to respond to a person in crisis, the person is less likely to be arrested and more likely to be connected to initial care than when a traditional policing response is used. And so training is critical in this space. And that training needs to involve working with families in addition to having the knowledge and skills to working directly with children. And to also remember that mobile response may not be limited to the child's home, but may be in a pediatrician's office or in a school or in an after-school program at a daycare center. And next slide, please. And finally, I asked you at the beginning to think about the somewhere to go. And what we heard overwhelmingly, and there was an awful lively discussion in talking about somewhere to go in the context of working with children and families, is can we think about a system of support? Because recognizing that when we think about a place to go, that can imply that we're taking the person, and in this instance, it would be a child, a youth, a young adult, out of a particular situation, may set them on a trajectory into the child welfare system, into the juvenile justice system, that may change the course of their lives when in fact we are trying to resolve a particular crisis situation. And so thinking about, can we think about this stage as building a system of support? We also talked a lot about in this space that the words that we use, the language that we use are important, and how the choice of how we select those words will guide our behavior. And so the folks we spoke to recommended that we think about using words such as coordinate, connect, support, to ensure that we're mindful of language access and cultural sensitivity. And also to consider that food and housing insecurity, financial hardships, and other stresses on the entire family system may be a much larger contributing factor to something that in an immediate sense looks as a child crisis situation, a situation for that particular child. So next slide, please. Whoops, and I'm going to have you go one more because we had, yes, here we go. I forgot to delete that one slide. So our path forward is we are scheduling additional listening sessions with families and with tribal grantees. And as our systems of care for children and adolescents evolve, we know that a comprehensive system utilizes mobile response and stabilization models to focus on these quality and systemic issues that we're changing care pathways and supporting families how and when they need the support. We're developing a customized trauma-informed crisis response system for children and families that will reduce demand for scarce inpatient beds, meaning we'll be able to reserve those high-end services for children and youth who truly need that level of care. SAMHSA believes a crisis continuum of care, which includes all three parts of the framework: someone to call, someone to respond, and expand how we think about somewhere to go, to include a system of support, a system to support that is specifically designed to meet the children and the needs of children and their families. So my ask of you today is that for your continued support and leadership as we fashion a crisis system for all Americans where we can ensure equity and access, and that we build a system that meets the unique needs of children, youth, and young adults in our families and our communities. So next slide, please. So my virtual door is always open. Please reach out if I can be of any help. So I hope I stayed within my time frame.
Melinda, that was amazing. And you're absolutely within your time frame because this is just so important that we do need to talk about that. And yeah, I do, before we go into the roundtable, I think just some of the things that I've heard from your presentation that were also reinforced at the SOSOZE conference, how the importance of language, right? And when we have a language of doom, that informs policies that continue that doom and programs and benefits. And so, we don't want to limit folks, and we want to make sure that we are preventing mental health emergencies and just calling out the themes of equity and access, and really not trying to fit the crisis into what is existing, but allowing individuals and their families to be active collaborators and have the services tailored to their needs. So this is phenomenal. I'm going to shift because I could talk about this all day. I'm going to shift to our roundtable and bring in Kana and Kevin. Kana, of course, is with McKinsey Consulting, and Kevin is with RI. If you all want to come on camera and unmute yourselves and give us your thoughts on Melinda's presentation. And also, Melinda, thank you, and thanks SAMHSA for the listening tours. It's so important to get that feedback. So thank you for undertaking that. Connor, Kevin, are you with us today? If not, I will turn to Brian Hepburn with Nashville. If you want to come off mute and share your thoughts with us.
Thank you, Laura, and thank you, Melinda. That was excellent. and music to the ears of the child divisions all across the country. Frequently, they feel like they are a second thought, afterthought, and what you're doing is putting them up front and helping to change the course of life in a positive way. We appreciate the SAMHSA prioritizing children, youth, and young adults. Also, appreciate the focus on equity and trauma-informed approaches. We also appreciate using the SAMHSA national guidelines for behavioral health crisis care and developing a parallel that will help with a special approach to children, youth, and young adults. So this was excellent, and I really can't say more than to say that we really support this, and we will do everything we can, Melinda, to work with you and to make sure this effort is a success. So thank you.
Thank you, Dr. Hepburn. Thank you.
Okay. Well, I'm not sure if we have Connor and Kevin with us today. I'm actually going to pause before we move to the next segment and see if there's any comments anyone wants to share, either in the chats. I know, Paul, you talked about the love the focus on creating an option for children. If anyone has any comments or questions and wants to come off camera and off mute to bring that forward, please feel free to.
All I would note, Laura, is this isn't easy, right? So when we're creating these systems, it's not easy for adults. Saying yes to all of them and creating a place where they can all come and hear the answer is yes, you're going to get care that makes sense, that's trauma informed, no matter what the challenge. And for children's systems, it comes up with the unique part of 4-year-olds can't be probably in the same place as 16-year-olds. And there are other parts that you have to do in your structure. So I think we're all thoughtful of it. And I think one of the challenges before all of us is that is going to be a little bit more expensive to create and deliver than others. But of course, this is about doing the right thing for these kids. And the more we create trauma by not connecting them to care, the more they are going to be challenged throughout their life. So I think we have to get this right now.
And Laura, this is Richard McKeon from SAMHSA. First, I'd like to thank my colleague, Melinda Baldwin, for her excellent presentation and for her support of the integration of youth suicide prevention into the broader context of youth mental health and youth crisis services. So thank you for that, Melinda. And we look forward to continuing to work really closely with you around these important issues. And we know that there's an intimate link between youth crisis services and youth suicide in the United States, particularly in terms of youth who, after getting acute care or entering the crisis system, don't get follow-up care. And we know from some studies, national studies of Medicaid, that those youth who do not get connected are more likely to die by suicide over the next year. So very important issues around youth crisis services and including follow-up after the crisis services to make sure the youth's needs are met.
Thanks, Richard. And Melinda, there's some questions in comments in the chat regarding peer support roles and places around the country. I see Washington and Oregon here where they've really incorporated that. Could you speak a little bit about the role of youth peer supports?
Yes, so that was also a lively discussion where youth were very adamant that youth peer supports be involved at all stages of this work, but also recognizing how important it is to frame that in a way that allows them to have a very positive contribution and that they're trained in that space. And so there was everyone we talked to is wanting to have peer support specialists, both from families and from youth involved in all stages of a crisis response.
Great. I know that's both something that everyone wants to be incorporated, both for the children's crisis system as well as the adult. So definitely glad to hear that that was part of the conversation.
The
I
other
may have
thing, if
missed-
I could just add, Laura, one thing is another comment in the chat is also that to have families and youth at the table when designing the system is incredibly important as well. So not just as peer support specialists, but in thinking about how to make the system responsive to families and youth.
Yes, yes. And I think, again, that goes back to having them as collaborators and really driving, tell us what you need. So this has been such a fantastic discussion. There was another question in the chat regarding timeline for the best practices to be available.
So my initial goal was by the end of the year. And of course, we know it's December 15th. So I hope to have this on the streets in January. That is our hope, that we will have drafts to review by the end of the year and then move it through clearance in January.
All right, well, perfect. We will stay tuned for that. Thank you so much, Melinda, for speaking with us today. And we look forward to the report. Okay, now we're going to move on to our next segment here in the Jam. And I'm going to turn it over to Stephanie Hepburn, who's going to talk about her interview with Jennifer Battle, who's at the Harris Center. And I just want to give a personal shout out and thanks to Jennifer for being a part in the Harris Center, being a part of the Lifeline Network. So we're very grateful for all the work you're doing in Texas. And so I'll turn it over to Stephanie.
Laura, and actually this piece was written by Kristen Nalon, and I highly recommend, as communities are building out their 988 systems, to look at this article, because Harris County, Jennifer goes through how they scaffolded the program, the obstacles they faced, what worked, what didn't work. It's a fantastic read. So thanks to Kristen for putting that together. It's an excellent piece. Jennifer, if you're on the line, Jennifer is the Director of Access at the Harris Center. She's also the co-chair of the Lifeline's National Steering Committee. And if you're on the call, if you could talk a little bit, one part that I thought was so essential for readers and leaders, community leaders, to read is that these calls, mental health calls, are scary for 911 partners, and that relationship and trust building is so critical. If you could talk about that a little bit.
Well, thank you for having me today. I'm always glad to talk about our programs and all the exciting things that are happening in Houston. And of course, anything that has to do with 988 and Lifeline is close to my heart. So when it came to, some years back, Houston and Harris County has been doing diversion work around trying to find what we kind of call right-sized care for people with mental health emergencies for many years, over 20 years. And so the relationship that we were able to build with our 911 public service access point was a extension of those years and years of trust building and success across many other components. What was challenging, or what was new information for some of our partners, was the work that the crisis line did. And sort of this idea that, we have this call center who was talking to people all day long, every day, who were actively considering suicide and who sometimes were, in the process of, potentially in that act or had weapons on scene, and that we were able to just handle those, often without even needing law enforcement involved in any way, by using all of our amazing active listening skills and collaborative problem solving skills, was really surprising to our law enforcement partners, because that is, of course, not the model that's used in a PSAP, in a 911 center. Which of course makes perfect sense, because law enforcement has their model and mental health services have our model. And so the ability to kind of create a Venn diagram of all the things that we agree on, that's important, and what the goals of each of our departments, programs, missions were, is ultimately we want to keep people safe, right? Like, we want people in our community to be safe, we want public safety, and we want people to be healthy, and we want people not to have to call 911 if they don't need to. And so, we we started this project years and years before the concept of 988 even was something that we're talking about now. So it's really fun to kind of have these conversations and collaboration now with 988 coming to the table.
I just would wonder, reading this article, like I said, it's incredibly fantastic. And I think it really lays the groundwork of the benefit of being co-located. I know communities have different situations. Do you have a strong opinion in terms of being physically co-located versus virtually located, where communities or behavioral health clinicians are tapping in through the CAD systems, but maybe not on the physical floor with the operations on 911? Do you have a strong feeling about which one they both would work, or one is better?
I just have a strong feeling that we should be doing the work, and whatever way that work looks like is the way that it should work for that community. The joke that we heard when we first started this project was, you've seen one 911 call center, you've seen one 911 call center, which is very similar to crisis centers, right? Like we have so much in common with our partners at these 911 centers. There's as many different ways to run a 911 center as there are to run a crisis center. And so, obviously Houston is a giant city, fourth largest city in the country, almost 5 million people. It makes sense, the capacity to have a full-time team located at this very, very large public service answering point makes perfect sense. But if you're in a smaller community where the volume is not so high, it doesn't make fiscal sense to do that. So we've consulted with, I don't know, 50, 60, probably some of you people on the phone right now, different municipalities and organizations throughout the country about this project, and provided tons of information as best as we can. We want everybody to have whatever version of this makes sense in their home community. So a lot of the people that we've talked with across the country, even some here in our own state of Texas, have, programs where people are not co-located, but there's been these wonderful collaborative conversations between those 911 centers and their local crisis centers to figure out how to ethically and safely, again, inside of that Venn diagram that we all want to be in, get those calls from people who may have called 911, but really are going to be better served by the crisis center skill set. And so if that means connecting a call live across, away from the 911 into the crisis center, great. If there's a way that the center is able to do that, that works really well. A loop back around, right? So if
that feedback loop
to the crisis center, and it really ended up after the amazing assessment and work with the crisis center counselor, specialist, responder does, that it really, there needs to be a separate response of law enforcement or EMS. How does that loop back into the system?
Right. Mm-hmm.
If those things have been worked out, then great. One of the benefits of co-locating is that everything that we do is still inside of the system. So the ability to stay in the computer-aided dispatch system and be able to be messaging dispatchers if we needed a response is wonderful. But the reality is that's not so often. Just like we know in our crisis line world, the majority of the time, you've seen all the stats and all your various crisis jam talks, 80-90% of the people that we talk to, we just handle it. We don't need an external source. They don't need to go anywhere. There's nothing else that needs to happen. The crisis line responder is the expert in that situation and provides that resource. On some occasions, we can send out mobile crisis. I love what we were just hearing about working with mobile crisis and youth. Big fan of that. Again, I think the collaboration and consent is so key. It's not any good to send mobile crisis out without consent, because you're basically almost kind of just doing the same thing that we've done to people with law enforcement. People have to want you to be there and really participate. And so that's been a beautiful part of this project too, is just being able to expand our mobile response to be able to provide the support. And so I was, listening to the presentation, and one of the things that was so surprising to me when we first started this program, almost 6 years ago, was the number of parents that call 911 because they're mad that their kid didn't get up and go to school that morning. So that first thing in the morning kind of call. It trickled down, of course, during COVID, but the first few years, I was just like, what is, and so we get on the phone and we talk with the mom or dad, and we talk with the kid, and we'd be like, what's going on? And it would almost always end up with kids gets up, gets ready, heads off to school. We maybe talk about a family counseling, response or referral. But that's it. And in some very rare circumstances, we could offer a mobile crisis referral, to have someone come out maybe later that day or after school and kind of talk with the family and figure out, like, are there next steps? Are there things that the family could benefit from? So having that crisis center connected and embedded, or either embedded or connected in some way with 911 is so powerful because it allows this whole other continuum of service that's available to the person that calls, other than, if you call 911 normally, you get law enforcement or EMS response or fire. Like that's the response. And that's what they're supposed to do. And that's what they do, which is wonderful. So if we can take off those calls that don't need that, then that Venn diagram increases the safety of our community, because it allows for those first responders to focus on the call that really needs that first responder response. So
Jennifer, I'm gonna slow you down there, because I want to make sure we give people time to read the article. We don't want to give too much away, but thank you so much for being a leader in this space, and really appreciate you being a part of the Lifeline and a model for this. And I think the themes that I'm hearing for this conversation today, it's collaboration, right? We really need to have these collaborative conversations, and including the people that we're serving, and 911 and other communities. So I'm going to move us forward. Next slide, please. And I'm going to turn it over to Richard McKeon of SAMHSA to talk about a report that came out today. And again, I just want to thank you, Richard, and the whole SAMHSA team for all the work and thoughtfulness that you all have put into 988 and 988 implementation. And I'm going to turn it over to you to talk about this report.
Okay, so I'm actually going to talk about two things, but first I want to thank Jennifer for the work that she's doing, and particularly for her hospitality. When 2 weeks ago I went to visit the Harris Center and visited the PSAP where they're co-located. It is an extraordinarily impressive operation, and it was very valuable for us at SAMHSA, for me to be able to go and to see the work they're doing in Houston, learn about the consultations they've done with other areas around the country, and then to go on to visit another excellent program in Los Angeles with Dee Dee Hirsch. So, thank you, Jennifer, again, for your hospitality and for your team's hospitality. So as Laura mentioned, there was just released one of the reports that SAMHSA has been working on. This was a report that was requested of SAMHSA when the FY 2021 appropriations bill was passed last December. So it is not the exact same report as was asked for in the Hotline Designation Act. There were two in the Hotline Designation Act, although we are very hopeful that that those will be following shortly. But what has now been released, it is on the SAMHSA website, is this appropriations report. And let me highlight a couple of things that are in there. It describes how SAMHSA is first focused on strengthening and expanding the existing Lifeline network, and how its SAMHSA's investment priorities for this current fiscal year demonstrate that commitment. And we're focusing on trying to shore up, scale up, and staff up the system. So there is $177 million going to strengthen and expand core Lifeline network operations and telephone infrastructure needs. That's $152 million in new funding and $24.6 million of the existing funding. And then to $105 million to go to states to build up the workforce across the local Lifeline centers. And we hope that more information will be available about that really, really soon. Like the Congress, we're hoping to do a lot before Christmas. And hopefully over the next few days, you'll be able to learn more. So I recommend that everyone go to the read the report that is now available. Many of the top line numbers are the same as what will be in the joint report with VA that will be coming shortly. I think it also does a great job of articulating SAMHSA's vision for 988. This is, these are major steps forward. But of course, the federal government can't do this alone. That's why we're funding and working with states directly on the critical efforts that they will need to undertake at the local and community level. And just as one other way, and my understanding is that in future crisis jams, we'll do a deeper dive into the report, but I recommend everyone read it so you can get the maximum value from that. I presume that would be in January. But let me just mention one other thing about why 988 is so important, why the National Suicide Prevention Lifeline is so important if you didn't happen to see it, if you are not a regular reader of the British Medical Journal. Earlier this week, a really important study was published. And this study, done by some of the leading suicide prevention researchers in the country, Thomas Dientherkaler and Maddie Gould from Columbia, among others, showed that after the extensive activity and publicity that took place around the Logic song 1-800-273-8255 at the Grammy Awards, at the and a number of other high-profile venues where that was highlighted, that we knew, of course, that we saw a spike in calls after that. What we didn't know until this report was that that spike in calls was associated with a drop in suicide. And the researchers estimate that hundreds of lives were saved through this. And interestingly, it's not just that there was publicity, it was the kind of publicity. And if you remember the Logic song, it's about somebody making a hotline call, wanting to die, working through it. It is a story of hope and recovery, right? So and the Wall Street Journal just published an article on this. It's been in many news media have covered this over the last couple of days. If you haven't seen the study, I would bring it to your attention. I think it's a really important area, and it just underscores the importance of the National Suicide Prevention Lifeline, of access to suicide prevention care, and the importance of the kind of messaging we put out. So thank you very much for the opportunity to do a SAMHSA report.
Thank you so much, Richard, for all of the work that you and the SAMHSA team, kind of on the slide here, have done for this report. And of course, we look forward to having you all back to go into more detail about that report. And also just wanted to reiterate, that the Logic song and the study that came from that, this is so important, particularly as we talk about 988 and crisis services and interfacing with other systems. The lifeline, right? The call is the intervention. This is proven effective. And so very pleased to see that. So I believe the link to the SAMHSA report has been placed in the chat by AFSP. Thank you so much. And we just have the Logic link posted there too. So let's move through. Richard, let's change over to Nashville, and I'm going to bring in Brian Hepburn.
Thank you, Laura. You've got Richard, Jennifer, Stephanie, Melinda, Laura. What a lineup. It's great. Good job. Thank you very much. States continue to work on 988 and crisis services, continue to work on workforce. Today, I wanted to say something about one of the leaders in states, and that's Doug Thomas. Doug Thomas the commissioner from Utah. He served as the director of the Division of Substance Abuse and Mental Health for the state of Utah for the last 8 years. I'm bringing him up because he's leaving his position and he's just been a force to be reckoned with in Utah and around the country. He was a critical voice in raising the issue of suicide prevention in Utah by creating the Utah Suicide Prevention Coalition and being an advocate for the expansion of crisis services in Utah and nationally. I think Doug would say his greatest accomplishment has been building an amazing team within the division that allows him to know that the system he has spent 26 years working in is in competent hands and that the partnerships that he has developed will continue after he leaves. Doug is very passionate about prevention, early intervention, crisis services, and integrating these efforts into systems to produce lasting outcomes to reduce risk and increase the mental and emotional well-being of individuals, families, and communities in Utah, and will continue to be an advocate in his next adventure. So I wanted to just highlight Doug and his contributions and to thank him and to wish him well. So thank you, Laura.
Thank you, Brian. And I just want to echo, I think we've got a little fan club started for Doug. Anyone who's interacted with Doug, I think would say the same. He is just an incredible force. So grateful for the state of Utah for really putting us on this path. And so sad to see, Doug move out of this position. Very excited to have him retire, right? Like he's earned a break. And I'm sure we'll see, he will still be connected with us as we move forward. Also wanted to highlight, Brian, do you want to highlight the slide as well?
Yeah, so I just wanted to say real quickly, Laura, that this is in the Crisis Now website. And if you scroll down, you'll see these papers. I wanted to highlight the 2021 paper that was done by Dr. Deborah Peinels. It's a paper, the umbrella paper that ties in previous year's papers with this year's papers. Deb does a really nice job. The paper is called Ready to Respond, Mental Health Beyond Crisis and COVID-19. So wanted to highlight and encourage you to read that paper. I think Megan was putting it in the chat. So thank you very much.
Thank you, Brian, and thank you to the entire NASHBID team. We're so fortunate for you. And now we're going to turn to Kim Myers, who's the Assistant Director with Utah's Department of Health, I believe is the correct agency. But Kim, if you want to come on camera and off mute. Thank you. Welcome. Glad to have you. So we're going to put you in the hot seat today. They're just a little different from the previous versions of the hot seat. So this version allows for the audience to put in their answers. And so the question this week, right, is that the Surgeon General, Dr. Vivek Murthy, issued a new advisory to highlight the urgent need to address the nation's youth mental health crisis. Right, so in 1999, the Surgeon General then proclaimed suicide was a serious blank problem. So if we can have the audience members put what your guesses are, Kim, we will allow you to go with the audience, see your own, say your own answer, bring anyone on. What are you thinking here?
Well, because I have been fortunate to be mentored very closely by Doug Thomas for many years, as he was an advocate for addressing suicide as a serious public health problem, and the audience seems to agree, I'm gonna go with B.
All right, let's see. All right, it's B, it's a public health problem. You know, I think this is really helpful when we talk about framing suicide prevention and we talk about getting away from that language of doom. So important to see it in this lens. Kim, do you want to talk a little bit about this, how you all have been viewing this in Utah, or anything you want to add to this?
Yeah, I mean, I was actually pretty terrified but I think I got one of the easier hot seat questions. So that I will say thank you for. But yeah, I mean, I think there was the report release that, half of people who die by suicide have a diagnosed mental health problem. And so just addressing it in the scope of mental health or behavioral health is insufficient if we really want to tackle this. So being able to have that comprehensive approach that brings in, public-private partnerships, that brings in upstream, prevention-oriented strategies, as well as treatment and crisis and across the board, and makes it kind of when it's public health, that means everyone kind of has that role. So really bringing in stakeholders, whether it be schools, workplaces. We've been able to do some really meaningful work within workplaces who are owning this as an issue of their companies, of their organizations.
Yes.
And I think if you just framed it as a mental health problem, then it would be kind of a, here's your insurance, you take care of it kind of thing, as opposed to really implementing strategies within the places where people spend their time. So
yeah, thank you, Kim. So important. And again, kind of reframing that narrative using the public health lens. And of course, this was the foundation, right, for the creation of the Lifeline. So ensuring that folks had 24/7 access, no matter where they were, to resources. So let's power through and go to the next slide. I am going to turn it over here to Sarah Corcoran to give us a federal update.
Great, thank you. And can we go to the next slide? Thank you. Okay, so since I think my last presentation, they have passed a continuing resolution to keep the government open and funded through February 18th of next year. So that's for FY22. On the reconciliation front, for Build Back Better, that passed the House a couple weeks back. And for the past few weeks, Senate Democrats and the administration have been talking with the Senate parliamentarian about the content of the text. Over the weekend, they released the Help and Senate Finance Committee text language for the bill, and we are expecting a procedural vote at the end of this week on basically a motion to move forward with the bill. At that point, we will see some of the more moderate senators, including Senator Manchin, will have to show their cards on if they're willing to vote for moving the bill forward, and then working behind the scenes on some things that they might have issues with, or if they will decline to vote moving the bill forward, and we will have to regroup in early 2022. So that remains to be seen, but hopefully by the end of this week, we'll have some indication if we'll see the bill move in the Senate before the holiday break. And then finally, just a quick preview next year on the January 5th first call of the year, the American Psychiatric Association fellow from the Congressman Cardenas' office, Eric Rothla-Yen, will be presenting about a great new bill that will be coming out next year on implementing 988 and the crisis care continuum. So definitely stay tuned and mark your calendars for early next year, hearing more about what Congress and the congressman are doing to move that implementation forward.
Great, thank you. Oh, I'm sorry, go ahead, Sarah.
Oh, I said that's it for me, thank you.
Oh, well, thank you, that's a lot. So it's not just it, that's a lot. And hopefully we will have some activity from Congress. So let's move to the next slide. And of course, this information will be available on that talk.crisisnow.com website. So you can have access to the slides and the video in case you want to refer back to it. So at this point, I'm going to turn it over to Hannah and Steph from NAMI to give us an update on the states.
Hi, this is Stephanie Pasternak with NAMI's National Office. Just briefly, one quick update on state legislation. New York's 988 legislation, S6194B, has been sent to the governor's office as of last Friday. If this bill is signed into law, briefly, it would do a few things. It would define 988 services and set out some requirements for those services for the call centers, mobile crisis teams, crisis receiving and stabilization centers. Stabilization services names the oversight agencies, sets out some 988 reporting metrics, how many people are served by 988, the demographics, what services they received, response rates, things of that nature. requires a funding study from the Office of Mental Health for 988. It's our understanding that funding study actually exists. It's just not public right now. What you did not hear me mention, of course, is that the bill does not contain funding itself, no dedicated funding for 988. And NAMI New York State and other advocates on the ground in New York are certainly raising attention to that fact and are pushing for some dedicated funding streams for 988, seeking if there's any opportunity to add funding into the bill at this point, or possibly if the FY 2022 budget is going to be an avenue for making sure that 988 has dedicated funding. So just a quick update there. And don't know if anyone else has on the line has any updates on other states as well.
Great, thank you, Steph, so much. Let's keep moving forward. I think we have about a minute left. That's the trouble with the jam. There's just so much information jam-packed. So let's go to the next slide, and you'll see that these, and you can keep going. These slides have been redone, and we will be spending some time talking about these, in particular Utah, in January. And don't forget, we are off the next 2 weeks, so there's a bit of a holiday break before we come back. And then actually, we're going to keep going. Sorry, Paul, we're going to have to skip you this week. I apologize. And just a quick look at what's coming up. There will be, of course, that SAMHSA operational readiness report deep dive January 12th. The legislation overview that Sarah told us about on the 5th when we come back. And again, just really great content. So appreciate everyone joining us today and look forward to seeing you all in January. Thank you so much.